Good evening, everyone. I welcome all of you on behalf of Maharashtra Academy of Indian Academy of Pediatrics. This is the most interesting part of the academic sessions, PG Case Forum. This is the session three, and we have a fantastic presenter here with expert and the examiners, the expert examiners for this particular uh, case presentation. Before I introduce the presenter and the examiner, I request Dr. Sanjeev Joshi sir to give the opening remarks.
A very good evening to all the Maharashtra IP, OB and EBs, Dr. Renu, Dr. Sanjay Nathu, Dr. Mahesh, and all our esteemed teachers from the various medical schools and the presenters. मला या नवीन विद्यार्थ्यांचा थोडा हेवा वाटतो की आम्ही जेव्हा पी जी करत होतो तेव्हा या सगळ्या फॅसिलिटीज नव्हत्या. अदरवाईज आम्ही पण नागपूर जी एम सीत राहून पुण्याच्या बी जे कॉलेजच्या ज्या फॅकल्टीज आहे, मुंबईच्या ज्या फॅकल्टीज आहे, दिल्ली वगैरेच्या आहेत, त्यांच्याकडनं आम्हालाही थोडंसं विद्या ग्रहण करता आली असती. एनिवे थोडेसे आणखी जास्ती आमच्या डोक्यात जास्ती प्रकाश पडला असता असं वाटतं मला. पण ठीक आहे, जेवढं आहे तेवढंच आता पुरेसं आहे असं वाटतं आहे. So I wish the entire team a great learning. Thank you all the esteemed faculties who have consented to be the expert today, and let the learning continue. आपण अजूनही लर्निंग फेजमध्ये आहोत असं मला वाटतं. मी अजूनही रोज अर्धा ते एक तास न्यूरोलॉजी वाचतो. बस हेच शेअर करायचं होतं आपल्या पी जी स्टुडंटला की लर्निंग इज अ नेवर एंडिंग प्रोसेस. एन्जॉय लर्निंग. Thank you once again, all team.
Thank you so much, sir, President Dr. Sanjeev Joshi, for your words of wisdom and encouragement to all of us. I'm sure this is going to help us. I request Dr. Renu Boralkar, Madam Secretary, Maharashtra IIP, to give us blessings for this program.
Yeah, good evening, one and all. Good evening, Mahesh, and also Madhavi, who have done a great job for organizing this part three session of PG case along with Dr. Sanjay Nathu sir, Dr. Bela Verma madam, and the whole team of scientific. And it is a great pleasure to have the young ones here on the platform. And I have seen Dr. Alka Jadhav, madam. She has said that she is coming for the first time. And madam, we are really privileged and honored to have you on the platform along with the other experts. And Ritesh will be having today exam. But don't take tension, Ritesh. In our days, we used to take tension, but nowadays tension is now normal. इथं जसं असतं की कुठलाही काही शब्द म्हणजे काही आलं, अरे मला टेन्शन आलं, आले मला डिप्रेशन आलं, हे नॉर्मल शब्द झालेत आजकालच्या जीवनामध्ये तुमच्या तर. And seeing the topic, I was amazed because now we are talking about the World Obesity Day and the week where we were saying that 1 in 10 children across the whole world is having the obesity, but still we are in the malnutrition phase. And so the today's case of pneumonia and malnutrition. In my PG days, we had Koshirkar and that is PM grading and everything about that. So I just went back in my days of learning, and so it is again to relearn today and de-learn today some things. So thank you so much for giving the opportunity and best wishes, Dr. Ritesh and his expert. And Mahesh, I would ask you to please ask Dr. Bela Verma ma'am, who is our convener, to give the words for wisdom.
I request Dr. Bela Verma, Madam, please give us the opening remarks, please. Dr. Bela Verma, Madam.
Yeah. Good evening, everyone. Nice
evening,
to
ma'am.
see you all again on an academic platform.
Good evening, ma'am.
And first of all, I congratulate the excellent work being done by the MAHA, OB, EB, and scientific committee coming each week with a better and good program. So I congratulate you all. Really good hard work. And may you all continue doing it throughout the year. I had just one suggestion that is up to you all to decide that whenever the case presentation is there, we should not reveal the system or the problem. Let it be a little surprise item for everyone. So, that then there will be a little element of eagerness, enthusiasm to listen to the whole thing without knowing the case till the end. So, just a suggestion. You could all think about it, and all the best for today's scientific activity. Okay.
Thank you. Thank you so
Thank
much.
you. Thank
Point,
you, all of
point,
you.
point very well taken. I think that is the best way to learn things because we are
Yes.
unbiased when we get the
Yes.
case in front of us.
I
And
think Bela has put forward a very fantastic idea. Actually, whenever we used to present the cases physically, there was no virtual platform in those days. So decoding of the case was done by the experts in
Yes.
those days. So I really like this idea. I think I request Dr. Madhavi and Sanjay Nathu sir and the entire team. So please
Yes, sir.
give a
Yes,
serious
sir.
note to it.
Yeah, yeah. Just
Yeah,
don't
yeah,
disclose the system or the
yeah.
case.
Yeah,
Thank you,
Let us
Bella.
all
Thank you.
attend it till the last to know what it is.
Yeah, yeah.
sure.
point
Thank you,
very
Okay.
well
madam.
taken. I think this is
Yeah.
the most important.
Yes, madam.
Yeah. Yeah.
Should we,
Okay. Yeah.
Madhavi
Yeah.
madam, do you have anything to say, Madhavi madam?
No, thanks all the experts for being ready for such a short notice because our usually the case is on the Thursdays, but because of some programs, it was rescheduled. And thank all my EBs and Dr. Mahesh for immediate response. Thank you everyone and our seniors, Dr. Renu Madam and Sanjeev Joshi sir. Thank you so much for putting faith on us and always motivating us. Thank you very much.
Let's jump on to the cases now. Before we start, let me introduce our experts and the examiners and the presenter today. We have Dr. Ritesh Pandey. He is the resident doctor from the Government Medical College, Jalgaon. We have expert Dr. Girish Rane sir, associate professor at the Government Medical College, Jalgaon. We also have the examiners, Dr. Alka Zadov. She's joining the Maharashtra IAP program online for the first time. We welcome her with a big heart. She is the professor at Terna Medical College, Navi Mumbai. She is also a former professor of pediatrics at LTMC Medical College in Sion and former additional professor pediatrics at PGIMS, in charge of pediatric gastroenterology and hepatology nutrition at LTMG. Her areas of interest of GI disorders, nutritional problems, and the management of obesity. She has been honored with Lifetime Achievement Award by Rotary Club of Mumbai in 2018, and she has a number of publications in her name. And we welcome with a big heart Dr. Alka Zado, madam. Thank you for joining on this today's session, ma'am. Welcome, ma'am.
Thank you. Thank you so much.
We have another expert, and I think he needs no introduction. Dr. Sushant Mane. He is the big name in the respiratory medicine in pediatrics. He's associate professor and nodal officer at National Center of Excellence for TB. He's the in charge of Pediatric Pulmonology Division, Department of Pediatrics, Grand Medical College, Mumbai. He has a special interest in pediatric pulmonology, especially pediatric tuberculosis, pediatric asthma, chronic lung diseases, pediatric sleep. He's also a member of National Technical Expert Group, National TB Elimination Program, NTEP India, and is a very great resource person for all the scientific platforms. We welcome Dr. Sushant Mane sir for this program as an expert. Thank you so much, an examiner. Thank you.
Thank you, Dr. Mahesh.
Yes. We have Dr. Girish Rane sir. He is again introducing him, associate professor at Government Medical College in Jalgaon. And may I request Ritesh Pandey to start with his case presentation. Ritesh, can you share the case?
Ritesh sir, are you there? I think he has left, sir. Must be network issue.
I will call you.
Yes, ma'am. Please.
He's joining back. He had some connection issues, network issues.
No problem. We'll be waiting for him. Meanwhile, let me thank all of you who has joined here on this platform today for the PG Case Forum. This will be an interactive session. Mainly, the case presenter will be asked and will be presenting the case, and the examiners will be asking the questions to the presenter, and the expert would assist in case of any ambiguity or any questions required. Ritesh, are you there now?
He had joined.
Will you be able to share the case now?
Ritesh sir, please try. You are co-host now.
Can you unmute
Please
yourself?
try.
Yes. Ritesh, can you start the case presentation?
Yes, PPT is visible.
Good evening, respected chairperson, esteemed judges, respected faculty members, and all my dear colleagues. Today, my name is Dr. Ritesh Pandey, and I'm junior resident in Department of Pediatrics at Government Medical College, Jalgaon. Today, I have the privilege of presenting an interesting case in front of everyone, and I am feeling great for having this opportunity to learn from such great faculty members. I'll be starting my case. My patient Jyoti Barela, 1.5-year-old female child, third issue, born of third degree consanguineous marriage, Hindu by religion, resident of Dharangao district Jalgaon, brought by parents with mother being reliable informant, came with complaints of cough and cold since 15 days, fever since 15 days, generalized swelling since 7 days, left eye discharge since 4 days, and increased work of breathing since 2 days. My patient was apparently all right 15 days back when she started having a fever which was sudden in onset, intermittent type, associated with decreased oral acceptance. Patient was lethargic and sick between the interfebrile period, not associated with chills, rigors, rash, and not associated with sweating. Patient also complained of cough and cold since 15 days. Cough was wet type, non-spasmodic, with no postural or diurnal variation, not associated with blood and sputum, associated with post-stressive vomiting, also
Ritesh,
associated with
sorry, just what is the age of the child?
1.5-year-old, ma'am.
Okay.
Associated with post-stressive vomiting, also associated with cold in the form of runny nose with whitish mucoid discharge, relieved partially with medication. It was also associated with mucopurulent discharge from the left eye since 4 days. Mother also complained of increased work of breathing since the past 2 days.
So
There
Ritesh,
was no history.
Are you justified in saying increase work of breathing?
I was coming to the same point.
Yeah,
So whenever
that's
you are telling
huh.
history, it has to be in the language what the parents say. So work of breathing is a very technical word, right? So what is the better word? How can you put it?
Hurried breathing, there was hurried breathing, the rate was more.
Yeah,
The child
breathing,
was,
fast
Or
breathing,
breathlessness, plain simple.
breathlessness. Simple. Because parents are not going to say work of breathing, hurried breathing. They will just say श्वास लागला है. So breathlessness.
okay.
Yeah, you can continue.
There was no history of recurrent bronchopneumonia requiring admission, no
No,
history
no,
of
no. But you
concentrating.
have to say if he has noticed breathlessness for 2 days, what have they done for two
They were
days?
taking, ma'am, in past history, they were taking
No,
OPD
it's
basis
not
treatment
past, it's
from,
an ongoing history, no?
Ongoing
yes, ma'am.
complaint.
Yes, ma'am. They were taking OPD basis treatment from a local practitioner on oral medications, which I've mentioned further.
No nebulization, no X-ray, nothing was advised. This is
Uh,
ODP, onset, duration, and progress.
yes, ma'am.
So whosoever has come with fever, cough, and breathlessness, it's purulent discharge from the left eye or right eye, and now for 2 days, if he is breathless, anybody will ask you what have they done for breathlessness.
Yes, ma'am.
So
Ma'am,
see, if you see the chronology of your case,
patient
the
was
child is
actually receiving treatment at local OPD.
no. This is the negative history. Go back to the previous slide. Go back to the previous slide. The same slide what we were talking about the ODP. Go back to that slide. Are you able to listen?
Yes, sir.
Yeah. So in this, what we no, the next slide, the slide next to this. In this slide, what we want to know is, see, the child is symptomatic since 15 days, right? So for 15 days, the child is taking some or the other treatment. Now, since 2 days, you say the child is breathless, right? So some new complaint has come up. So in 2 days, what did the parents do for that breathlessness? That is what we want to know. They were still at home. Was the child admitted somewhere else? Was he, in a village place or in a place where there are no facilities? Sometimes what happens is they take the child morning, evening, or 3 times a day to the doctor. They might be giving some injections, or as somebody, madam said, maybe giving nebulization. So all that detail should come here when you say breathlessness 2 days, because it has come to you after 2 days of breathlessness. That means they are doing something in that 2 days. They are not sitting idle, right?
Yes, sir.
Yeah. So you have to describe that when you talk about ODP. Go ahead.
Uh, pa- uh, Patient received treatment at local OPD. Oral medications and antibiotics were prescribed. Syrup, cefixime, syrup, paracetamol, and nebulization was received for 5 days. Parents did not do any treatment for the when there was increased work of breathing for 2 days. They were receiving nebulizations. They were advised admission to get admitted, but since parents were daily wage laborers, it was difficult for them to get admitted. They were referred from a primary health center, Dharangaon, to GMC Jalgaon via ambulance. After which they came and they got admitted in our pediatric intensive care unit.
Go back to a negative history again. So when you say about recurrent history of bronchopneumonia, again you can frame it in a better way. Recurrent history of chest complaints requiring treatment with or without admission. Again, bronchopneumonia is a technical word. That is one thing. Why have you asked the history of cyanosis, suck, cycle, or forehead sweating?
To rule out congenital heart diseases, sir.
To rule out congenital heart disease. Okay, so is this the first
Yes, sir.
episode of
Yeah.
illness which the child is having in 1.5 years?
The child was having child had 2 to 3 episodes of cold and cough, which was resolved on OPD basis, sir.
In this 15 days, right?
Yeah, this one is 15 days, sir.
We are talking about previous to this 15 days. Did the child have repeated complaints of any respiratory complaints previous to this 15 days?
The child had complaints of cough and cold, sir.
How frequently? And
Uh,
since what age did the child
for
start?
every 4 to 5 months, sir. To requiring at least 3 times OPD basis treatment.
Is
So
it
every,
normal
is it,
or
yeah.
abnormal?
Uh,
So you say every
it
three to
could be
four
normal.
months, 3 to 4 months. So roughly it is how much? 3 times in a year, right? If it is every 3 to 4 months, it is
Yes,
around 3 to 4 times in a year. The child was having cough cold, right?
yes, sir.
Yeah. So what? So you have to go into details. Cough cold.
Yes.
So how do you know on the history whether this cough cold was a upper respiratory tract infection or whether it was a lower respiratory tract infection? Because that is going to change your negative history again. So you say that the child was having 3 to 4 episodes every year. Child itself is 1.5 year. So that means right from birth the child was symptomatic, or what age the child started developing symptoms first. So see, these are very nuances in the history what we should pick up so that you have a provisional diagnosis what system is involved. Okay.
Yes, sir.
For example, why we are asking this is when we talk about heart disease, which is the heart disease, which type of heart disease comes with recurrent LRTIs?
Uh, so, ventricular septal defects or
So
atrial
basically
septal defects,
the acyanotic ones, right?
So they are left to right here,
Left
acyanotic,
to
right?
right fronts, right?
right
And what
defects.
is their age of presentation generally? First
For
time present.
VSD, sir, for VSD, it could be present as early as 1 month. For ESD, they can present
So
after
basically,
one
four
year
to
or
six weeks.
when it could be incidental finding.
Yeah, so basically 4 to 6 weeks, right? That is the presentation for a hemodynamically significant congenital heart disease to present. It will present at 4 to 6 weeks with the first episode. And when you talk about recurrent episodes, are they LRT or are they URTI?
They were URTI.
URTI. So when you talk about heart disease, it is LRTI. It is never a URTI,
URTI, sir.
right? So that is what we are asking. Clinically, how will you distinguish whether it is a URTI or LRTI? On history, what are the pointers?
It could be it would be associated with fever. The cough cold would be productive cough, and there may be decreased acceptance to oral feeds. There
Okay.
might be a noisy breathing.
What is the specific sign or symptom which distinguishes a URTI from LRTI? Fever can be present in both. Difficulty or poor feeding can be present in both. For example, a bad pharyngitis or tonsillitis, there is pain in the throat, odynophagia, the child will not eat. He will cough, vomit it out. Okay, so what is one sign? It is there when you read about pneumonia also, your IMNCI also gives that sign. That sign is going to distinguish or symptom between a URTI and LRTI, which is
Sir,
there.
retractions,
Yeah, so fast breathing basically with or
fast
without
breathing.
retractions. So if your patient is having fast breathing with or without retractions, which means something is going wrong in the lower respiratory tract, it could be your parenchyma, it could be interstitium pleura, anything. So that is how you dissect the history. So when you talk about recurrent infections, you have to talk whether there were recurrent URTIs and recurrent LRTIs. Now, madam asked a very pertinent question: is it normal? How many times a year a normal child would have URTIs?
Sir, 2 to 3 times.
Up to, so if the child once the child crosses 1 year of age, 12 months, okay, goes into the toddler group, okay, around 4 to 5 times is normal. When it goes into the school going age, 6 to 8 times, sometimes 10 episodes are normal. It all depends upon how much contact the child is coming to with his peers or the other children. This is very important. First, whether it is URT or LRTI, how many episodes, and then what was the treatment taken. Okay, for an LRTI, you can say oral medications taken for 5 days, maybe 7 days. URTI just symptomatic treatment. If the parents are able to give you the history in detail, okay, what is the, sometimes the parents also tell the name of the drug. Okay, paracetamol was given, or amoxicillin was given, whatever. Okay, so this has to come when you're talking about your ODP, and then you jump on to the negative history. Why have you asked the history of foreign body ingestion in this patient?
Sir, increased work of breathing. There was increased work of breathing. There was arid breathing.
Okay, so how does a classical foreign body present?
It will be, sir, very acute. Presentation will be very acute. Child
Yes.
will present on the same day, and there will be increased work of breathing. There will be decreased voice production or no voice production.
So voice is related to your voice box. Okay, foreign body is the voice, the foreign body has to be very large for it to block the larynx. Mostly it is lodged in one of the main bronchi, that is the right more than the left. Okay, and as you said, it is a sudden acute presentation. What is the predominant symptom in a foreign body? It is not increased work of breathing or breathlessness. If something goes wrong in the airway, what is the reflex mechanism? What happens to the body?
Cough, sir.
Cough. So we will
Cough.
present with dry cough,
I had been
momentless
cough.
cough. Okay, and it may or may not be associated with a history of visible choking. The parents would sometimes, if the parents have noticed, there will be a history of visible choking. Now, if you compare that with your history, your child is ill since 15 days, is running fever on and off, cough is going on and off, and suddenly since 2 days, he started giving breathlessness. So this is not what a typical foreign body would like, present. What else you should have asked in the negative history?
Uh, Sir, acceptance to oral feeds.
Okay, that is true. Then
Sir, couch or any couch contact. History of couch or any couch
that is
contact.
TB. Okay. 15 days complaints. You ask history of TB contact. How do you ask the history of TB contact?
Sir, if there's someone who has been coughing since more than 7 days or 10 days, if there's any history of weight loss, if there's the child is not able to gain weight, or
Specific,
if
how do you ask history of contact?
Contact.
sir, if family members who have been diagnosed with tuberculosis in past 6 months, or since the child has been born, or if there's any active TB contact, active TB cases present in the community or in the
Yeah, that
local
is very
area or in the
important.
family.
So don't only stress upon the family members. Any person with active TB who comes in close contact with the child. We have had cases where there was no contact in the family, but there was some child in the school, okay, or some child in the classes of the child, wherever. So you have to ask anybody coming in close contact with the child would be having a history of uh, TB, treatment for TB or symptoms of tuberculosis. And decreased urine output is for
Uh, Sir, decrease since there was decreased acceptance and there was no decreased urine output, there was no sign of any dehydration.
okay. So that is one is it will indicate dehydration. Now in your child, the child was having on and off complaints since 15 days. Since 2 days, the child has worsened. So decreased urine output would be another sign of what? What is going wrong in the patient? One is dehydration. Okay, if the child is having vomiting, loose motions, we talk about decreased urine output. Another thing is, especially with
If there's any signs of shock, sir, signs of shock
yes,
or
so
any signs of sepsis.
it is actually a very late sign of shock when the N organ shutdown has started occurring. Okay, so that becomes an important sign. So whenever you write negative history, first is you try to localize the system. Then once you localize the system, go on to what is the commonest etiology of that system. Like for example, here we are thinking of pneumonia, and then the final history would be of complications. Okay, so that is how you divide your negative history. Go ahead.
Yeah,
Yes,
actually, I wanted to tell you the textbook of preventive and social medicine gives the definition of Cox contact beautifully well. Means
Yes.
if you have a family member who's staying with the child is important, or who's visiting the child at least once or twice a month, and who's staying in the vicinity of 100 meters should be taken as Cox contact. Like when we have a Jhopadpatti, the neighbor will have Cox.
Yeah.
Yeah. And nowadays, if you have a Cox contact, you have to ask whether it is a regular Cox or MDR Cox. So that is something because right now in our ward we have two miliary tuberculosis with one MDR with contact with MDR Cox. It's that way. Okay, go ahead.
patient received treatment from at local OPD. Oral medications and antibiotics were prescribed. Syrup cefixime, syrup paracetamol, and inhalation received for 5 days. There was no prior hospital admissions documented.
So this is okay.
So,
This history is
so
fairly.
he deteriorated despite of the nebulization for 3 days, correct? He developed
Yes, ma'am.
breathlessness.
Yes, ma'am.
So before he developed breathlessness, somebody had started nebulization already.
Yes, ma'am.
Okay.
What is the issue with the antibiotic given here? Cefixime. So you are talking, we are considering a respiratory infection, right?
Yes, sir.
Yeah, probably a LRTI. We will,
Yes,
I
sir.
mean, as we go ahead, we'll come to LRTI. So what is the issue with the
Yes, sir.
antibiotic? It is the right choice of antibiotic.
So since it is a third generation cephalosporin, we usually go for the first step is for covering mainly gram positive organisms, which is may be due
Yes.
to
So
amoxiclav,
what is the spectrum of cefixime? Why?
cefixime.
Hmm. Cefixime covers what kind of organisms? You are right.
Uh, Sir, it is a third generation cephalosporin, mainly covering gram negative organism and
Yeah, so it is
some.
exclusively for gram-negative bacterial infections, right? Below the diaphragm, you say. So when
Yes,
you
sir.
talk about above the diaphragm infections, okay, mostly are gram-positive, which are
Yes, sir.
community acquired. Hospital acquired could be gram-negative, but community acquired above the diaphragm are usually gram-positive. So the choice of antibiotic when you are giving an empirical therapy has to consider the etiology. I mean the organisms what you are anticipating, and then you give. Probably if he would have received an appropriate antibiotic, probably he would not have deteriorated. Okay, so it all depends, right? Okay,
Yes.
go ahead.
Birth history. Baby, mother was registered. Regular USG scans were done with regular follow-up. Iron folic acid and calcium supplements were taken, but it was not. She was not taking it regularly. There was no history of fever with rash, radiation exposure, teratogenic drug intake. It was a full-term delivery, normal vaginal delivery. Baby cried immediately after birth. Birth weight was 2.1 kilograms. No history of any birth asphyxia, no NICU stay, and baby was discharged on day of life 3.
Was she primary or multi?
She's a ma'am. She was multi gravida. The baby is third issue, ma'am. Third issue, born of third degree non-consanguineous.
So she's
Consanguineous.
gravida 3, para 3,
Yes, ma'am.
with
G3,
all
P3.
two living issues, all three living.
Yes, ma'am. All three living.
Birth spacing
Birth spacing was not adequate, ma'am.
means
Means what was the
Uh,
duration in pregnancies?
the first child was 4 year old. Second child was 2.5 year old. Third child was
is they are alive, na? Was
yes,
nahi.
ma'am. They
Huh.
are alive, ma'am. They are alive.
Huh. So first is 4 years, second
Yes, ma'am.
is
2.5 year old.
and the third one is now 1.5 year old.
1.5 year old. And there
So
was
she
also a
remained
fourth child.
pregnant in third month of pregnancy, a
Yes, ma'am.
third month after the delivery.
Third month after the delivery. There was also a fourth child, ma'am, which was a 4 month old male child.
And what happened to that?
The child was with the mother.
Is not so don't say was. Means we feel the
Who is?
child is okay.
So
So
she has
who,
four children.
Yes, total 4 children.
my God, all four living with 1 year difference between the two.
Hardly 1 year, ma'am.
So what have you advised her?
Ma'am, we had advised.
You have.
Yes, ma'am. We have advised uh, birth control methods, ma'am. We have advised them to get a tubal ligation done.
Why not vasectomy?
So,
You should counsel the couple itself. Na? Now four children. So actually they should undergo the permanent sterilization methods. Have you advised?
yes, ma'am. We had advised, ma'am.
Okay. But till they take come to a consensus and now the child is 4 month old, before fifth child comes, what will you do? I'm sorry, the distraction, but it is very much required. Every
No,
year,
I mean,
one child.
it's relevant. The child is
Yes, ma'am.
suffered nutritionally, so this is a very relevant discussion.
Yes.
So till the time they come to a consensus, what can you advise?
We can give them birth control pills or OCPs,
Will it
oral
not
contraceptive
affect
pills.
her lactation?
Progesterone only pills, ma'am.
Okay. Second one,
Second
Second one, ma'am, we can ask them to undergo vasectomy or tubal ligation.
but that till the time they decide.
till the time that, see, birth control pills is okay. One problem is lactation could be affected. Second is, if your parents are that negligent that they are having children one after the other, they are not going to take your pills on a daily basis. So what is the other option?
Barrier method, sir, or
They would
copper
have
T.
used it already. They would have used it already if they were sensible enough to know that.
Copper T insertion, sir.
So the name for that method is, what is the
Intrauterine device,
yeah, intra
contraceptive.
yeah, intrauterine devices.
Okay. Fine. Go ahead.
Immunization history. Child has not yet been immunized with any oral or injectable vaccines.
Oh my God. And the
Reason,
fourth one, what is the immunization history of other children?
Other
yeah.
no any siblings were immunized. Even the child which was born latest, the fourth issue, even the fourth issue was not immunized. We had advised every child to get immunized on discharge. The patient which was admitted was also advised to undergo immunization, and rest all siblings were advised to undergo
Means
immunization.
why was the immunization refused?
Why have they not given immunization to their kids?
Uh, Actually, the parents were very much daily wage laborers. They were they were belonging from a tribal community, and the immunization awareness program was actually they couldn't get through the benefits of the immunization awareness program of the that
Do they
primary health
have,
center.
so if they are from a tribal area, do they have access to any sub center or a PSC?
They had access to a primary health center, sir, which was
So,
located actually 8 kilometers from their place of work.
so that is okay. 8 kilometers is okay. Primary health center. So that their tribal area, whatever pada or they call, it must be falling under some PSC or sub center, right?
Yes, sir.
So what is the Government of India protocol? What happens if the parents don't go to the PSC for vaccination?
We go for immunization every home. The protocol is to get every child immunized and
How? The
go.
parents are not
We
going. The parents are not going. So what does the government say if the parents are not taking the child?
to counsel the parents and to reach every place, to reach every
Who
home.
does that?
ASHA worker or
And
LHW or Anganwadi worker, sir. They reach every home, they reach every house,
there are
and they get.
ANMs, there are ASHA workers who go and counsel. So you said that because they were in a tribal area, they didn't have knowledge. So that question does not arise. The government program is so robust that even if the patients don't know or not aware, the health team will go to their place. Okay. So in spite of that, if the parents are not vaccinating, then it is our responsibility to go in deeply into the reasons why they are not giving. Probably they have some fears about vaccination or myths about vaccination. See,
Yes,
there
sir.
are four kids, none of them is vaccinated. So this is very unusual. And nowadays it is there in right in the nooks and corners of the country that immunization has to happen. The sub center and the PSC staff is held responsible if any child is found not vaccinated in that area. Okay, so you
And
need to
this is unusual when she has attended the antenatal clinic.
yeah, absolutely,
Yeah,
absolutely,
And was it a home delivery or a hospital delivery?
it was a ma'am home delivery,
all
How
four.
come home delivery attended by trained birth attendant or attended by a non-trained birth attendant?
non-trained guy, ma'am.
How is it possible? Fourth.
They were very tribal community, ma'am. Actually, they
नहीं
were
agreed,
elected
but
to.
इतना भी आजकल कोई ट्राइबल नहीं है.
That is what now
I
the
don't know.
it is
I
very
mean,
contradictory, very hard to believe.
very hard. She
You-
going to the antenatal
Ah,
and
Yeah,
delivering at home. There is
yeah.
some problem with your history taking, I feel.
And in fact, if she's going for the antenatal visit, the ANMs and the nurses are more cautious. Nearing to the LMP, they will give visit to their house
Yeah.
more frequently to see if she
And
is
then
having.
how then birth weight was 2.1?
Ah, for
Who
home delivery.
recorded the birth weight? If it is
they
attended by somebody who's a non-trained birth attendant and 2.1 birth weight किधर से मिला उसको?
they went to a Anganwadi, closest Anganwadi, the on day 7 of life, and
So
where they
were they not given birth vaccine at that point?
no, ma'am. Actually, the mother did not give any history of any vaccination. We asked them if
Why
there
did
was
they
any
go to
scar.
Anganwadi on day 7?
Yes, ma'am.
Why
Why
did they
did
go to
they
the
go to
Anganwadi?
Anganwadi on day 7?
Ma'am, since there was a visit by Anganwadi worker, they asked the mother to get the child and get vaccinated, but the parents were reluctant about the vaccination.
So that is the real reason. Okay, it is
They are
not
reluctant about vaccination
the
of every
not
child.
the knowledge. Parents are reluctant. And again, when you say they went, I mean, the weight was done on day 7, so you mentioned that in your history. It is not the birth weight. Okay, if it is a home delivery, the birth weight is not taken. At day 7, there was some issue. Either they went to the Anganwadi or the Anganwadi worker came. That time the weight was done. So it is not the birth weight, first of all. And second, now you're saying that she went for vaccine, I mean, convinced for vaccination, but the parents have refused. Okay, so again, when you say that you have advised them to vaccinate, they are not going to do it unless and until they are convinced enough to take immunization for the previous children also and this child also.
Now, if this child has come to you, he gets all right. What vaccines will you give him?
Uh,
Now he is 1.5 years old.
yes, ma'am.
Tell you. Sushant will be the best person to know whether he's saying right or not.
So we're talking only about national program. Tell us
Uh-huh.
about that. At 15, 18 months or 16 months, what are the vaccines which he is eligible now under the NIP?
The child is eligible for MR vaccine, DPT
Hmm.
vaccine, vitamin A,
Hmm.
and yes, ma'am. DPT
Pentas,
boost,
pentavalent,
DPT, MR, vitamin A, and
pentavalent.
pentavalent.
Will he be eligible for pentavalent and pneumococcal, or what are
Not
the
eligible for pentavalent, sir.
why?
Since pentavalent, a maximum last dose can be given up to 1 year of age.
Up to 1 year. So he'll be not eligible for those pentavalent and rota and anything right now. Okay, go ahead.
Developmental history. Developmental is appropriate for age, all milestones achieved, no developmental delay reported.
Again, very difficult to
Oh,
believe.
how can it be possible? Low
What
birth weight baby.
low birth weight baby, failure to thrive or not growing. What is the current weight of the child? He's 1.5 years.
6 kg, sir.
So he's 6 kg. So it is less than -3 HD, right?
Yes, sir. Less than -3 standard deviation.
So
So
tell
how
us what all milestones he has achieved, what all sectors, and what is he doing at present. That is your developmental history.
yeah.
Yes. At
Normal or not normal, that we'll decide.
yes. At present, in gross motor, the child can walk. Child can walk. Child started walking at 1 month ago, 16 to 17 months of age, and in social,
No.
child is.
Walking, you have to describe the walk. Na?
Do you know the stages of walking? How does the child start walking?
Fine, you read it up. So now this is really out of the context, but child is able to walk. But okay, then fine motor.
In fine motor, ma'am, child was able to scribble. Child could scribble on a paper, which was achieved 2 to 3 months ago.
2 to 3 months ago, that is 15 months. Now he's 18 months, right?
At 15 months of age. Now the baby is 18 months of age.
Okay. So
Very, very early he is achieved.
scribbling generally occurs at what age?
Scribbling, baby achieves at 18 months of age. Along with they can feed with spoon. The child was able to feed itself. The child was able to eat from the pot itself.
Okay.
Okay, language.
Language, there was a language delay, but then there was catch up. The child could catch up all the milestones later. The child could
How
say
many word
at least
sentences he is
8 to 10
speaking now?
words 8 to 10 words vocabulary.
Does he speak short sentences?
Not able to speak short sentences, but child could address her mother, address her father, and and her siblings.
Okay. So there is definitely a little gross motor delay, but about language, unless we assess, I can't say.
Go ahead.
Dietary history, there was 24-hour dietary recall.
Oh my God,
In
you have
the
to start with breastfeeding. Child is less than 2 years. So all that history, when was the first feed given, pre-lacteal feed, how many food groups, so all that thing. This is not the dietary history.
Exclusively breastfed, predominantly breastfed, not breastfed. I mean, there could be anything, right?
Then complementary feeding started when, who feeds the child, how many food groups she is having, what is the dietary diversity, what is the minimum acceptable diet for his age, and what are the calorie intake, protein intake, and then what are the deficiencies. That will make your complete dietary history.
Yeah. So this comes in a table. So what? Go to the previous slide. So this 24-hour dietary recall is now. So you have to start right from the birth till 6 months, then 6 months complementary feeding, how it was started, and then come to this present 24-hour dietary recall. And your protein and calorie intake would be on this current, what you say, 24-hour dietary recall.
So this is pre-illness dietary recall. Go back.
Pre-illness or during illness?
What is this dietary recall? Because he is
Pre-illness, sir.
sick for 15 days.
Pre-illness.
That's why I'm asking.
Yeah.
Pre-illness dietary recall, sir.
Before 15 days, right?
Yes, sir.
Acha,
Okay.
just one question. Was the child breastfed anytime?
The child was breastfed as well, sir. Mother
Right
used to
now,
breastfeed.
at 18 months, is he still feeding on the breast or he stopped
Yes,
breastfeeding?
yes, sir. The child was still being breastfed, sir.
How come there's another child who's four
There is
months
another
old, so
child.
she is
Yes, ma'am.
breastfeeding both?
Both.
Since the child was not able to sleep, mother used to say ki, the child was only sleeping after she used to breastfeed
So
at the
what is
night
that
time.
known as? What is that known as? It is not breastfeeding. That is a sleep association. That means the child has got used to falling asleep due to some action, which is known as a sleep association. For example, one of the things what you explained, the child will just keep on suckling at the breast. He is not actually feeding. Another thing is taking the child into the arms and rocking the child. Okay, these are all sleep associations. So that is not breastfeeding. If the mother is saying that if the child only sleeps when he is put to the breast, that is a sleep association, and that is a negative association at this age. Okay, the child should not be used to that. So there is a so if she has a lower sibling of say 4 months, it is very unlikely that she is feeding both. By the way, what is the weight of the mother?
Fate of the mother, sir. Uh,
So you know
Andage.
malnutrition starts with maternal malnutrition.
Yeah.
So you have to know the weight of the mother during pregnancy. What was the weight gain? And right now, if you are having a child at 18 months, another child 4 months, is the mother well enough nutritionally? So all this is important. Go to the next slide.
This is dietary analysis. Total calories approximately were 450 kilocalorie per day. Protein intake was approximately 5 gram per day. Expected calories was around 1200 kilocalories per day. Expected protein approximately 24 gram per day.
1 minute.
Diet was
How?
inadequate
1 minute. 1 minute. Don't go so fast. See, your total calories is 450 kilocalories. What is the present weight?
6
present
kg.
weight is 6 kg, ma'am.
So, what is the expected calorie intake for the present weight?
For the present weight, it is 600 kilocalorie, ma'am.
Agreed. And what is the expected calorie intake for the expected weight?
What is the
Ma'am, expected it is 1200 kilocalories, ma'am.
Okay. So, what you have to say is for the present weight, also his calorie intake is not
Not
sufficient.
sufficient, ma'am.
Okay. Fine. The same way you have to give both for the present weight and for the expected weight. Both. Okay. Hmm.
Diet is inadequate in protein, calories, and micronutrients.
No, but for that you have to tell us how many food groups he is taking. Is he using green leafy vegetables? Is he using yellow orange fruits? Has he received some vitamin A enriched food? Does he eat egg yolk? So all that before you say conclude that it is not rich in micronutrients, you have to tell me the food groups.
How many food groups are there? As far as
At present, only 3 food groups are present, sir.
No, no, no. How many food groups are there in total?
in total IYCF.
Uh, and
So you have to read up that, right? And you have to ask about each food group. Then only you will come to know what type of micronutrient is deficient into that child.
5.
Okay. So your diet analysis starts from breastfeeding till day. Okay.
General physical examination. On admission, the pulse was 132 beats per minute on right radial artery. Respiratory rate was 46 breaths per minute. Peripheral pulses were well felt. Central pulses were well
No,
felt.
no, now you describe your respiratory rate of 46 since the child is breathless. Describe it completely how you will describe the respiratory rate. Or you are describing
Child
it because it's a general examination. Are you describing it in respiratory examination or
Yes,
you want to?
ma'am, I've described it separately in the respiratory examination.
No, but in general examination, ma'am, we have to describe because the
Yeah,
child is having, yeah, you have to say it at both places.
because it is vitals.
Yeah, yes, absolutely. So describe the respiratory rate. What is madam?
Respiratory rate was 46 breaths per minute, and oxygen saturation on room air was
Not
No,
saturation.
no.
What else you describe in respiration? First of all, is the rate normal for this child or abnormal for this child?
abnormal, sir. It is tachypneic. The
Okay.
respiratory rate is more
What else
than.
you want to describe? You said that
Sir,
in the second slide where we told you that you cannot. No, no, don't go back. You said something in your second slide where we told that you cannot use that word here because it has to be in the parents' words.
yes, sir.
Work of breathing.
Increase
Uh,
work of breathing, sir.
so how do you
So
describe?
how do you describe that? Now you are examining, so you have to tell.
There will be subcostal retraction, intercostal
No, no, you
retraction,
have to say
In,
there where or there will be. Don't.
in this patient, what was the finding?
There was subcostal retraction, there was intercostal retraction, there was a nasal flaring, there was suprasternal retraction,
Hmm.
and
And
increase abdominothoracic respiration, sir.
okay, any noisy breathing?
Associated with noisy breathing, yes, sir.
What type
Or
of noise?
stridor. What was it? Inspiratory noisy breathing or stridor or what was it?
Rider, wheeze, grunt, rattles. So now you're
It was
examining
expiratory grunt, sir.
expiratory grunt. Okay, fine. Go ahead.
Child appears sick and malnourished, drowsy but arousable, sparse discolored hair, protuberant abdomen, generalized edema present, oxygen via nasal bronchs. Anthropometry weight is 6 kg, which is less than 3 standard deviation. Length was 72 centimeters, which was also less than 3 standard deviation.
Minus
Mid-upper
3
arm
standard
circumference
deviation. Less than minus 3 standard
less than
deviation.
minus 3 standard deviation. Mid-upper arm circumference was 11 centimeter, which is criteria for the severe acute malnutrition. Head circumference was 43 centimeter, which is less than minus 3 standard deviation. Weight for height was less than minus 3 standard deviation. It is consistent with the severe acute malnutrition criteria.
Okay.
But before that, go to the previous side of general examination. So, generalized edema present. Where was the edema? How do you describe edema?
If it is pitting or non-pitting, and
Agreed.
if it started from the abdomen or if it started from the face, and if it worsens in the evening or if it worsens in the morning, if it increases in the morning or
No, so
increases.
describe for this child how it was present, where what is present.
Generalized edema was present, ma'am. There was a bilateral pedal edema, and
Okay.
facial edema was also present, very or
How
wide
does
associated with
IMNCI grade edema? +1, +2, +3?
0, 1, 2, 3, ma'am.
0 is no edema.
Yes, ma'am.
How the +1 is edema where?
+1 was present in the bilateral pedal edema,
Where?
and in abdomen it was also +1,
No,
ma'am.
no. +1, don't run. I mean, don't jump.
Pedal where? Ankle, foot, knee, thighs. That is what we are asking.
Ankle, sir. It
It
was
is on the
present on the ankle.
dorsum of the foot. Okay. First, it comes on the dorsum of the foot, then it comes near the ankle. So that is +1. Bilateral pitting pedal edema on the dorsum of the foot. Then +2 is
From the dorsum up till knee, ma'am.
so below the knee.
Below the knee.
Okay. +3
From lower limb up till upper limb, ma'am. And facial and
thighs and sacrum. You have to look at the sacrum to know whether there are pitting or not. And +4 is anasarca or generalized edema. Okay, so this child, you mean to say he had anasarca? He doesn't look, I mean, the whatever photo I am able to see.
No.
Sushant, you agree for anasarca?
Doesn't look like anasarca.
His eyes are so wide open, he doesn't have any.
Have you seen a nephrotic child?
Yes, sir.
So that is anasarca. Okay? He is hardly able to open the eyes. The face appears bloated. Everything, limbs are swollen. So this child, I mean, the face structure and everything is seen very clearly. Hardly any edema what we can see.
So by and large, +3 should be there if you are saying so much of extensive edema. So imagine with such an extensive edema, weight is only 6 kg. So what is the edema-free weight of this child? Okay.
Yeah, go ahead.
He was drowsy but arousable. In your general examination, what did you do?
Ma'am, to check for dehydration, we had skin pinch.
Yeah.
We did skin
But
pinch.
why he should be dehydrated when he had no diarrhea?
Ma'am, there was decreased acceptance to oral feed, ma'am.
Okay. But what should you do first? Before you start the oxygen, what will you do for a drowsy child who has come to you, who is malnourished?
Uh, Capillary refill time, ma'am.
You will do a D-sticks, no?
D-sting. Yes, ma'am.
So you will do a D-sticks and you will find out what is his sugar intake before, and so you start on oxygen, look at his temperature and maintain. So first is emergency. For a drowsy child, emergency management is important.
Yes, ma'am.
Okay. Right.
So in your
Drowsy means arousable only. No, drowsy but
yeah, yeah.
arousable means what?
Drowsy means arousable, right? Awake, able to awake with stimulus.
Yeah, that is drowsy.
Yeah. So in your anthropometry in the next slide, okay, we just go to the next slide. So here, okay, your interpretation is Sam. Now if you see here, see that is how mistakes happen. Head circumference is less than -3. That is microcephaly, right?
Microsoft.
Now if you go back, you are telling us that developmentally the child is normal. Does it correlate?
No, sir.
So never make such blunders in the examination. If you have not taken history, say that you have not taken or you have mistaken taking the history. You are giving us a striking figures that the child is having microcephaly with SAM with so much of this thing. You don't expect the child will be developmentally normal. As far as our experience goes, the child will be affected in all four domains, not a single one, but all four domains.
Yeah,
Okay,
true.
so go ahead.
Head examination. There was sparse thin hair discoloration. There was no scalp lesions present.
Okay,
Okay.
fine. What
Hmm.
about fontanelle?
Fontanelle was closed, ma'am.
Oh God, 18 months closed fontanelle.
Yes,
No
ma'am.
vitamin D deficiency.
Yes, ma'am. There is vitamin D deficiency as well.
So how can fontanelle be closed?
Malnutrition with you have said it is micronutrient deficiency,
Hmm.
and how do we expect that the fontanelle is closed?
Fontanelle was closed, ma'am.
Okay.
Okay, next.
We believe you that it was closed. Maybe outer table, whenever you have a closed fontanelle, you have to say whether the inner table or outer table.
Yeah.
Especially 18 months, that between 15 months to 2 years, you have to say inner table closed or outer table open. So you have to describe that.
Yeah, go ahead.
Hmm.
Uh, Face examination, sunken cheeks and irritable expression,
ये
malnourished
sunken
face
cheeks
expression.
किधर है तो उसके फोटो में sunken cheeks तो है ही नहीं.
Ma'am, this photo was taken on day 14 actually, ma'am.
So you should have I mean it is misleading. No, you should have had a photo on day 1.
Even again, see, even if you say it is on day 14, do you expect a Sam child? Sunken cheeks is marasmus according to old classification, right?
Yes, sir.
You think in 15 days the cheeks will come up so much
No, sir.
for a marasmic child? So there is some discrepancy in what you're describing and what we are seeing. So you have to be very careful. Okay, sunken cheeks. I mean, if there is that means there is loss of buccal pad of flat. Absolute grade 4. Okay, 7 दिन 10 दिन तो उसको I mean he will take to come back to normalcy.
Especially edematous child.
Especially
उसको tick
edematous.
sign आएगा.
हाँ, उसको टिक साइन आएगा.
He's got such good cheeks.
Hmm. Okay, go ahead.
Eye examination, there was left eye discharge present, left eye leukomalacia, right eye corneal cirrhosis, mild conjunctival congestion was present, pallor was present, there was no icterus or cyanosis.
So is it an emergency? Now with this finding, what will I do or what will you do?
Ma'am, we will start with the vitamin A doses for the corneal
What
cirrhosis.
dosages? Tell me exactly what dosages and how will you give?
Ma'am, from 0 to 6 months, 50,000
अरे
international
हाँ,
units.
इसके लिए बोलो
This,
ना.
this, this child.
Okay, ma'am. For this child, 2 lakh international units on day 0, 1, and 14, ma'am.
But do you want to give orally? When you have keratomalacia, when you have involvement of the cornea, don't you want to give injectable? So first 2 dosages he will receive injectable on day 0 and day 1. 1 lakh units, he is less than 6 kg. So how much he will receive?
1 lakh international units, ma'am.
Less than 6 kg. Injectable is half the oral dose.
Yes, ma'am.
So he'll receive 50,000 international unit on day 0, 50,000 on day 1, and 1 lakh unit orally on day 14.
See, one, this is an emergency. Second, he's a malnourished child. Do you think he's going to tolerate the oral drug? Okay, his absorption is going to be affected. Okay, malnutrition affects all the systems, right? What happens to the gut? There is villus atrophy.
Yes,
Okay,
sir.
there are symptoms of malabsorption. Okay, you don't expect whatever you put inside, especially those vitamin A doses, are going to get absorbed. So that, and this is an emergency. So that is the reason the first two doses have to be parenteral. I am.
Yes, sir.
Whenever you have a corneal involvement, it is an emergency. It's the preventable cause of blindness. Otherwise, you will need keratoplasty. Okay, the child, actually, the visual area is already involved.
Hmm. Okay, go ahead.
No, one more. Why he's got pallor T plus? So, do you think when child has worsened on nebulization, come to you on day 3, fifth day of nebulization, and now he's got generalized edema and 3 plus pallor, is it not one more emergency?
Yes, ma'am.
What is it? What is the emergency?
Congestive cardiac failure, ma'am. Due to severe anemia.
So, what was your heart rate or pulse rate?
Ma'am,
One,
heart rate was
146,
132, ma'am.
132. Was it okay or was it tachycardia?
It was tachycardia, ma'am.
What is the normal heart rate for 18 months old?
Uh, 100 to 120 beats per minute, ma'am.
By and large, around 120 is fine. So, this was a non crying heartbeat.
Yes, ma'am. This was a non-crying heart rate, ma'am.
Okay. So, what did you do? Apart from the D sticks, what did you do?
Ma'am, we started on inotropic support. We started on dobutamine support,
That's
and then
fine.
we started on inotropic support for the child. We gave oxygen supply, then oxygen supply by bubble CPAP. We started on inotropic support with dobutamine at 5 microgram per kg per minute. We also gave transfusion
So, your
at,
diagnosis was she was anemia in failure.
yes, ma'am. It was
What
also
was the
anemia with failure.
urgent hemo? Did you do an urgent like D sticks? Did you do a salicylic acid hemoglobinometer bedside?
No, ma'am.
The
or you could-
IMNCI mentions it, isn't it?
or nowadays, if you when you have your coulters available, you can immediately do a coulter and get an hemoglobin, right? That is again an emergency. So blood transfusion in this patient or pack cell transfusion becomes an emergency management. He's having pallor, he's having signs of congestive cardiac failure, and he's having grade 3 edema, right?
Anyway, for our information, what was the hemoglobin in this child?
Ma'am, it was 3.1 on admission.
Okay.
There was microcytic hypochromic severe degree anemia, ma'am. Menzer index was 16, ma'am.
Okay. So in that case, if you have urgently transfused, how have you transfused him?
Ma'am, we started slowly at 5 ml per kg. Then we gradually, after 24 hours, after 12 hours, we again give transfusion at 7 ml per kg after checking the CBC. On admission, it was 3.1, ma'am. Uh, on day of discharge, patient's hemoglobin was 9.8, ma'am.
So the thing is, 5 per kg is okay or good as per the standard books, but we follow the practice that if you have a hemoglobin which is less than 5, say 3.1, we would give 3 cc per kg slowly. If it is 4 cc per kg, that way.
Okay, so that is one thing. We have managed anemia. Okay, what else you should have done in this patient as far as your anemia is concerned?
For anemia, sir, we did anemia workup, which was we followed up with peripheral smear with a sickling test with the reticulocyte count. We also set HB electrophoresis for this child.
What was the
And
result?
yes,
HB
sir.
electrophoresis was normal for this patient.
Sir, it was normal, sir.
Okay, Why this is particularly important in this child? So most of it can be explained by his nutritional status, or B12 deficiency, everything, because it comes into micro and macronutrient deficiency. But particularly for this patient, why is
Why
HPLC
is
important?
it important?
You told us right in your first slide.
Tribal community, sir, which
And
is where sir there
Which
might be
anemia is
hemolytic.
common in tribal
Yes, ma'am.
Maharashtra?
Ma'am, can you, ma'am?
which anemia is common
Maharashtra,
in the
which anemia is common in tribals of Maharashtra?
Sickle cell anemia, ma'am.
Sickle cell anemia. Okay. So we
and
have
is
really
also
working up
consanguineous
for
marriage,
hemolytic anemia, correct?
Yes, ma'am. Hemolytic anemia.
right? And there is also consanguineous marriage, right? Third
Yes, sir.
degree. So it
Third degree
makes it
consanguinity.
high risk for these hemolytic anemias.
Yes, sir.
Okay.
So simultaneously, did you work up for the mother for her anemia also?
Yes, ma'am. We simultaneously worked up for the mother as well because mother was also anemic. Mother was also pale and she also was anemic, ma'am. Her hemoglobin was 7.2, ma'am.
And breastfeeding the child.
Yes, ma'am.
Yeah, fine. Okay. So
Yeah.
the X classification of vitamin A deficiency, I'm sure everybody knows, so I don't have to worry.
Yes, ma'am.
But you said right eye X2. What about left eye? Leukomalacia means what is the
Left eye, ma'am, since it is there is corneal ulceration, ma'am, which is more than one third of the cornea, ma'am. It is X3B, ma'am.
yes. Okay. So which was very, very severe. Nowadays we have stopped seeing such cases. Huh? Actually, I don't know. I've not seen it since a long time.
Hmm.
Hmm.
Yeah. Go ahead.
There was no ear discharge. Uh, Nasal prongs were in situ. Nasal flaring during respiratory distress. Oral cavity was dry. On neck examination, there was no any lymphadenopathy. Trachea was central and no neck swelling were present.
Hmm.
So nowadays, actually, head to toe means they describe head, then the face, then the neck. Is it this way? I don't know. We were never describing like this.
Hmm.
Sushant must be knowing. I'm old timer now.
They describe generally one part by part, HFN, neck, then the abdomen, chest, everything.
Acha, is it that way only, आजकल? Okay, fine. Go ahead.
Chest examination on inspection.
अरे
Child was conscious.
systemic examination कभी आएगा? This you are describing in general examination only, na?
Yes, ma'am. Inspection, palpation, percussion, and auscultation.
So respiratory system examination
Yes, ma'am.
you're doing. Okay.
The child was conscious but irritable due to respiratory distress. Tachypnea was present. Chest indrawing present in form of intercostal and subcostal retraction. Nasal flaring was present. Use of accessory muscles of respiration were present. Bilateral chest movements were reduced. Rachitic rosary along with Harrisel sulcus was noted. Trachea appears to be central. There was
My
no
God,
scar sinus or
rachitic
dilation.
rosary you found in a child who's Sam.
Ma'am, there is rachitic. I have a picture, ma'am.
The question is, if he is not growing, why rickets will come? Rickets is a disease of growing bones. So if you get a rosary in a SAM, what things you should think of?
Vitamin D deficiency rickets, ma'am.
No, no. Is it scorbutic rosary?
See, it is very simple. Unless and until the bone is actively growing, the osteoid portion, you're not going to get rickets. In SAM, the growth is stunted. So that is why you should think of conditions other than D, that is C. Okay. How do you differentiate clinically between rickets and scurvy rosary? I mean, scorbutic versus rachitic rosary.
So there will be bleeding gums will be present in apart from the bone and joint involvements. There will be bleeding gums and
What rosary specifically? And
Rosary. How do
scorbutic rosary, sir.
Yeah. So what is the characteristic of a scorbutic rosary and a rachitic rosary? Bleeding gums is okay. You are giving us extra
Sir,
signs.
scorbutic rosary is tender on it is tender on touching, sir, and it is pointed and oval shaped, sir.
Pointed. Okay.
So you have to, we believe that since we have not seen the child, but most likely it is scorbutic because he's having pallor, he's having vitamin A deficiency, multiple micronutrient deficiency, because vitamin D is not growing only. So how will it come? Okay.
Okay.
Or you can see a costochondral junction because he is so thin that that prominent costochondral junction only you are mistaking
Yeah.
it for rosary.
Yeah.
Yes, sir.
That is also a possibility. Okay.
Yeah. Next.
नहीं रोजरी इतना क्लियर तो नहीं दिख रहा है वो कोस्टोकॉन्ड्रल जंक्शन ही रहेंगे
Yes, sir.
ठीक है
Okay. Next.
On palpation, the trachea was central, chest expansion was decreased bilaterally, and tactile vocus fermentus was increased over areas of consolidation.
How do
There
you know?
was no
by
chest
and
wall
large
tenderness.
How
such
do
a
you know?
small child huh? Yeah, that's what sir was asking.
See, TVF or VR is increased over consolidation. That is a knowledge what we have. How do you know that the child has consolidation? Why there is no effusion? Why there is no collapse?
Sir, on percussion there was dullness, sir.
So no, you talk about palpation. So never write increase over area of consolidation. You write your finding and then you say what is your interpretation. What was the tactile vocal fremitus? Reduced, increased in this patient.
Sir, phonating words, sir. We use phonating words.
Tactile vocal fremitus you do with your hands or ears.
Sir, ears mainly, sir.
How?
Eh?
Tactile.
And hand, sir.
Tactile.
Ulnar border of the hand is kept
Yeah.
on the intercostal space,
Okay.
and
Yeah.
we ask the child to say phonating words.
Yes. Okay. So in this patient, was it normal? Was it decreased? Was it increased? Simple.
Sir, it was increased more on the right mid zone and the right lower zone, sir.
So you have to talk about whether it was increased and in what areas of the lung, right? You have anteriorly, you have 4 areas, you have posteriorly 3 areas, and laterally you have 2 areas. So you have to specifically say on the right side, on the left side, in which areas you got the TVF to be increased. And then you give your interpretation whether it was consolidation or effusion or collapse. Don't say it is increase over consolidation. That means you already know that there is consolidation inside. That is not what is expected in examination, right? So which all areas the TVF was increased?
Yes, sir.
Which areas the vocal fremitus was increased? Tactile vocal fremitus.
Sir, it was increased in the right upper zone, right mid zone, right lower zone, left mid and left lower zone, sir.
That is both sides.
Yes, sir.
Okay. Then in percussion, dull note.
Dull percussion note over lung fields of right upper zone, right mid zone, right lower zone, left mid and left lower zone, sir.
Okay.
And resonant percussion was noted in remaining lung areas.
Which are the areas which are remaining? Everything is involved. No? Left middle, left lower, right upper middle, lower. So it is bilateral disease, you mean to say.
Answer axillary, sir.
Okay. Axillary it was resonant.
Yes, sir.
Okay. What else you do in percussion?
We also focus, sir, on the scapular area, sir. Suprascapular, interscapular, and infrascapular, sir.
Anteriorly something you do on the clavicle.
Yes, sir. At the apex to checks for consolidation at the apex. We
So
directly percuss at the and clavicular bone, sir.
was it there or it was not there?
So no, sir, it wasn't there, sir. It was a resonate, sir.
So apex is paired.
Yes, sir.
Okay. Go ahead.
On auscultation, air entry was reduced bilaterally. Bronchial breath sounds were heard over right upper zone, right mid zone, right lower zone, and left mid and lower zone. Bilateral coarse crepitations along with inspiratory cackles were present all over all lung fields. Increased vocal resonance was present over right and left mid zone, sir.
So two, three things. One is bronchial breath sounds are heard everywhere, right?
Yes,
Okay,
sir.
so what is the type of consolidation you're dealing with here, or type of pneumonia pathologically?
Sir,
What are the
lobar
pathology? Lobar pneumonia. Okay,
Yes, sir.
so it is bilateral extensive lobar pneumonia. That is one. So on the right side, all the three zones are involved, right?
Yes, sir.
Okay, so how do you know on the right side whether it is only pneumonia or there is associated effusion?
On the right side, sir.
Yeah. Or how
If
do
it's
you, in the right lower zone, there is also a liver which comes up, right, in the lower intercostal spaces. So how do you differentiate in the right lower zone? You said you're getting dull note, you're getting whatever dull note on the right lower zone. How do you know it is not because of the liver and it is because of the
So
pathology in
we
the right?
ask the patient to take deep inspiration, and on deep inspiration, after that we do percussion.
What
If
is that
on deep,
you have noticed? What is
if
that?
on after deep inspiration, if there's still a dull note present, then it
Mhm.
is due to consolidation, because on deep inspiration the liver is pushed downwards, sir.
So what is that method known as? There is a word for it
Uh,
on percussion. You have described the method. I'm asking you what is the name of that? That is known as what? Tidal percussion.
Tidal percussion, yes, sir.
Yeah, that is tidal percussion. Okay, go ahead.
There was no pleural rub or there was no V's present.
Hmm.
On cardiovascular examination, S1 and S2 were heard. There was no murmurs detected. Peripheral pulses were palpable. No signs of there were signs of cardiac failure. Actually,
Okay.
there were signs of cardiac failure.
No signs of cardiac failure. How come?
Yes, sir. Actually, there were signs of cardiac failure. I couldn't edit this. I was
Was there any gallop rhythm or anything? Murmur, gallop rhythm? With hemoglobin 3.1, no
yes,
murmur,
ma'am.
no
Actually,
gallop is
there was tachycardia, so the murmur could not be appreciated at the time of admission, ma'am.
at least a gallop rhythm. Okay, ठीक है. Go ahead.
Abdominal examination. The abdomen was protuberant. Skin hyperpigmented patches were present. There was no dilated veins. Umbilicus was central and inverted. On superficial palpation, there was no mass, swelling, or any lump detected. On deep palpation, liver was palpated 5 centimeter below right costal margin. Spleen was just palpable. Kidney was not
1
palpable.
minute. Whenever you are describing the liver is the largest organ. You always have to describe right lobe of the liver in mid axillary line, left lobe of the liver in midline, and then the span. So describe right lobe and the left lobe at least. Not only in hepatic, in all cases. Because anyway you see the liver, see right lobe, left lobe, why not describe? Okay.
That's one.
And also the span. Here you have just said 5 centimeter below the right costal margin. What is the liver span? That you have to write.
So, so
Hmm. What about
actually,
fluid in the abdomen?
When he has anasarca.
yes, ma'am.
So have you looked for it? How do you look for fluid in the abdomen?
So we percuss, sir. We do percussion, sir.
So
There
that you have
are
not. You have from palpation.
horseshoe-shaped dullness, or sir,
So was it looked? Was it examined in this patient?
yes, sir. It was examined, sir.
So
But
it is not.
it was a tympanic note, sir, on abdominal examination on percussion, sir.
So that is means normal or abnormal.
Sir, normal, sir.
So there is no fluid in the abdomen with so much of
Sir,
circle and a hemoglobin of 3. No third space losses.
fluid was
He was a male child or a female child?
female child, ma'am.
Okay, so no genital edema, vulval edema not there.
Yes, ma'am.
Okay.
Okay, go ahead.
Extremities and extremities, there was muscle wasting of limbs. Bilateral pedal edema was present. Widening of bilateral wrist joints present along with narrowing.
I mean, I can't see wrist widening.
Yeah, I can't see.
The uh,
Okay.
on neurological examination, child was conscious but irritable.
Normal. Go
There was
ahead.
no
You
focal
have to give us
neurological
the
disease.
diagnosis now.
Uh, Bilateral bronchopneumonia with septicemia with iron deficiency anemia with congestive
Again,
cardiac failure.
you
One
said
one at a time. Bilateral bronchopneumonia,
all
septicemia,
the findings you described were of lobar pneumonia. Now, why are you saying it is bronchopneumonia?
broncho.
That is why I asked you specifically when you told me the RS examination. What is the interpretation? You said it is lobar pneumonia, which is okay. Whatever findings you have described fit into the diagnosis of lobar pneumonia. Now, here you can't write bronchopneumonia then, right? And with septicemia, why do you say septicemia?
So there was fever since 15 days, which was not resolving on antibiotics, and so there was also cough cold since 15 days.
So fever
The sir,
15 days, cough cold since 15 days could be non-resolving pneumonia or it could be TB. Why
sir,
specifically septicemia? What are the
uh,
features which suggest that this child is into septic shock? Septicemia is septic shock, right?
yes, sir.
So what are the features which suggest that this child is in septic shock?
Uh, so there was signs of failure as well.
Hmm.
There was tachycardia, there was tachypnea, sir.
So that is,
There were high grade
Shock
fever,
is
which was
different from failure.
yeah. So cardiac
fever were
failure.
associated with chills and rigor,
What type
and
of shock you get in septic conditions?
What is the
and
type of,
there was also decreased acceptance to feed.
no, no, what is the type of shock you get in septic? How septic shock is classified under what type of shock? What category of shock?
uh, wa- Warm shock or cold
No,
shock, sir.
don't read what is put in the chat box. We are asking you, there are three basic classifications of shock, right? What
Yes,
are
sir.
those three? Septic
Uh,
shock is under one of those. Have you heard about distributive shock?
yes, sir. This is hypovolemic shock, distributive shock, cardiogenic
No, no,
shock.
hypovolemic is completely different, sir. Hypovolemic is a separate category. One is
Yes, sir.
distributive, one is hypovolemic. These are two different kind. Third is cardiogenic. Your distributive consists of your septic shock and your neurogenic shock or anaphylactic. Okay, so you
Yes,
have
sir.
to know your basics. So whatever you're saying, there is tachycardia, there is failure, and all. This is all explained with your two primary conditions. One is your hemoglobin of 3 and bilateral extensive pneumonia. The patient is going to be in tachycardia or failure, right? So
Yes, sir.
specific indicators you have to pick up of septic shock. And why do you say iron deficiency anemia?
Since what it was microcytic
How
hypochromic,
do you
sir.
go on clinical examination? You have done history and examination. On clinical examination, how do you know it is microcytic hypochromic?
Uh,
In the exams, you don't read
so
report.
the
So hemolytic,
hemolytic facials were absent, sir, and
What is the IMNCI classification of anemia?
huh,
You would put it as IMNCI classification, no?
yeah.
it is, ma'am, nutritional and uh,
It depends on severity of the anemia, not on the etiology. See,
Whether it,
clinically, you can't say unless it is he has doesn't have hemolytic faces, he
yeah,
doesn't have periungual hyperpigmentation when we looked at it. So probably you
yes,
can
ma'am.
you can
but
say
There was
probably
no
nutrition.
hemolytic facials, probably nutrition.
Here, first you have to say whether it is a severe anemia. That is what we are asking. What does IMNCI say? Severe anemia, non-severe anemia, क्या है वो classification? And probably you can say probability.
Severe anemia, sir.
हाँ, nutritional is a probable cause. Like again, we during your presentation we asked you about did you send electrophoresis or what was the HPLC report. That is okay, that is negative. But when you are giving your final diagnosis in the exams, you don't have reports. This patient is a tribal
Yes,
community.
sir.
This patient is having a third degree consanguineous marriage. There could be more than one cause for anemia. Okay. and your hemolytic phases may not come up at 15 months or 18 months.
So he is severe anemia in failure. That's
Yes,
all.
yes,
Okay.
with bilateral pneumonia, lobar pneumonia, with severe acute malnutrition. Okay,
With vitamin A deficiency,
yeah.
XB and okay. See, in all these examination, you've never said what happened to his vision, preserved or not preserved.
Lesion, ma'am.
Vision.
Vision was preserved, ma'am. Actually, left
Check.
eye vision was not normal. Left eye vision was, ma'am. Actually, we were planning for the child to have refractive correction, but
Isn't
left
it
eye vision
very
wasn't normal.
unusual that this child never had a photophobia despite of corneal involvement? That is something which is
What is the earliest sign of vitamin A deficiency?
Night blindness, sir.
What history? What history do the
Mother
parents?
gives the child couldn't find the mother at the night time, or the child falls while walking or while
That was
running,
not there
or
in this patient, and directly presented with corneal ulcer. That is what we are trying to ask. There is no history of photophobia. There is no history of night blindness, and the child. I mean, the child has directly come in a corneal ulcer, which is an advanced stage.
any history of measles in the past, because you have to ask that history never came in a negative history.
uh,
Measles or measles like illnesses. Okay, fine. So I think Sushant, you want to go ahead for discussion, or I think
So I
I'm
think it's done.
I'm
Almost.
done.
Yeah, yeah,
1.5 hours.
yeah,
Enough of grilling on the clinical side only. So
yeah.
you want to give a final diagnosis, you have to give a social whenever there is a severe acute malnutrition. This is only the presentation. What are the contributing factors or confounding factors that you have to say to rule out tuberculosis? Also, you have to mention what all things you want to rule out. So it's a really a big diagnosis, social diagnosis. So you want to try once how to complete your diagnosis.
yes, ma'am. The provisional diagnosis could be, ma'am, bilateral lobar pneumonia with a probable nutrition deficiency with congestive cardiac failure, with vitamin A deficiency, with vitamin D deficiency, with severe
Vitamin
acute.
D we have not agreed. Possibility, possible, but neither the wrist widening nor the rachitic rosary is so.
With severe acute malnutrition.
Edematous type, that also. All three criteria this child is fulfilling.
Yes, ma'am.
Okay, with unimmunized status. That is also very important. That has to come in the final diagnosis. The child is completely unimmunized, and possibly due to what are the social factors which are led to these two factors? At least we can say. What are those?
Birth spacing wasn't adequate, sir. Inadequate birth spacing.
One, second.
And, sir, low birth weight of the child, and
So that low birth weight would be a consequence of poor birth spacing. So one is poor birth spacing. Second would be low socioeconomic,
awareness, sir.
and third would be lower awareness.
Awareness.
Okay, all these three are contributing. There are multiple factors. There is not a single factor which contributes. There are 3 to 4 factors which are contributing in this particular child.
Okay, fine. So, Dr. Madhvi,
Yes, ma'am. We are here, ma'am. Dr. Sulashan.
no, shall we? Because now we can't, because investigation and management becomes a part two of the lecture, where obviously me and Sushant would like to be there. So, Ritesh, once more with one more Sam with pneumonia.
Yes, ma'am. Done, ma'am. I'll try my best, ma'am, to do
I'm
better
remembering
than
I'm remembering my postgraduate days, madam. We're so fortunate to have both of you, and the discussion is too grounded. I was in a dilemma whether to take OSCEs before or not. but then it's a better decision that we did not go ahead. In fact, I had asked Dr. Sushant Mani sir whether he will be giving us one or two. He
Yeah.
was occupied. We have prepared three, four, but I think it's a good decision. But with the permission of MAHAIP, I think we will continue for the next session also. Let us, me and Mahesh, talk to, yes, Dr. Mahesh?
Yes, yes, absolutely. I think this was the excellent case presentation and excellent examiner's points of view has been discussed. I think this was one of the best case presentation on the
Yeah, I mean,
discussion.
it is very much rooted in day-to-day practice, whatever we are coming into the public hospitals. And it's very important that the residents understand rather than going into the only newer technologies or investigations, clinical examination is the thing which you can imbibe in a public hospital where you are learning so that it can be applicable in the practice very properly in the resource restraint areas, constraint areas. Very well done, both the experts. I mean,
Thank
Dr. Mahesh, you can formally take over again.
Nope, no worries. Thank you, everyone, for attending this session. And first
And
of all,
we want Dr. Rane also, no? Rane was also the third one.
yes, Dr. Rani sir, any inputs from your side, sir?
Yeah, that's what.
So it was a very nice session, and my student will be benefited, and in fact, all the faculties will be benefited, attending faculties.
But I'm feeling so sad that you are getting such awful cases from that
Yes,
tribal
ma'am.
area, unimmunized, home delivery, which is should not be a scenario.
Yeah.
Actually, we have frequent cases like that, ma'am,
Oh God.
in our
Nowadays,
area.
we have stopped seeing such cases now.
Okay, okay.
That
That is probably in our MMR region or metropolitan regions where we are staying, locating, or practicing even in the public hospitals. Probably the awareness and reaching to the healthcare facilities in the government hospitals also in a peripheral area would be difficult. That's what I feel now. It's a long way to go.
Yeah.
yeah.
And
Actually,
credit goes to Asha worker also. They bring us such patients
Hmm.
at the right time.
yeah, really. Thank you so much for inviting us. Sushant, your last words, and then we wind up.
Also very happy after a long time, we have got a thing to discuss, like an exam case presentation, and especially with madam. She is my teacher, my mentor, my family, everything. So we have a very close bond.
Thank you, Sushant.
Same thing goes with me as well, madam. And we are very lucky to have both of you.
Absolutely. I think this was the best points discussed today. I think this was clearly very well taken by everyone. And the case presented by Dr. Ritesh Pandey was also quite
Good.
systematic,
Yeah.
and it was quite clear. And he also had a lot of kind of points to give us to us.
Correct.
And his presentation also quite in a systematic manner, I think. And he could answer most of the questions.
Yeah.
I think this is a learning phase for him, and definitely a lot of things will be there for him to learn from this. And his preparation is also there, his confidence level is also good. And a lot of clarity has come after the discussion, I think.
Yeah.
And special
Actually,
thanks.
really a well prepared case, and he has
Absolutely.
taken efforts to present it.
Absolutely, absolutely. And a special thanks to the examiners, Dr. Sushant Mane and Dr. Alka Zado, madam. I think they have given a lot of valuable inputs to this particular session. And there are a lot of suggestions from your side that will definitely taken positively by all of us. And Dr. Ritesh is definitely going to work out on his preparations on those points. Definitely an enriching discussions for all of us. The guidance what you are giving is definitely going to help all the PG students for their exam preparations. I think that is the main objective of this particular session by the MAHAIP. I think on behalf of MAHAIP, I thank Dr. Alka Zado madam and Sushant Mane sir and the expert Dr. Girish sir also and Ritesh Pandey for this particular session. Thank you everyone for attending and giving your inputs. We will definitely take this case in terms of investigations and the treatment part and the rest of the discussion which is remaining. We will discuss with the other MAHA EP members, EB members, and the office bearers. about the same case being continued in the next session.
Yeah.
Any input, Dr. Madhavi?
No,
Otherwise,
thank you very much. I just request Dr. Sushant Mane sir to keep a day again reserved for our
Yeah.
MAHAIP case forum. I'll convince madam, she's more than happy to share her views. So just a request, Dr. Sushant Mane sir, from your busy schedule so that we can complete this case properly and we will spread a word of this case discussion amongst the PGs also.
Yeah.
Because this is what is very much important.
Many of our PGs had actually logged in because we told them in the morning. So many of our PGs were already there.
Okay.
Yeah. Yeah. Thank you so
So
much.
we'll
Thank you.
continue
Thank
the
you once
second session
again.
as well.
Thank you. Thank you so much.
Thank you once again. We will
Thank-
leave the meeting now. Thank you so much.
Thank you.
Thank
Thank
you.